welcome the other panelists that they can join me. So as been said, I'm Danielson. You can call me Kennedy. I have some long names. So please allow me to introduce the panelists as they come along. So I will start with Dr. Brenda Obondo. So Dr. Brenda Obondo is the CEO for the KMA. Please give a round of applause. You have the privilege of choosing wherever you want to sit. So she sits in the senior management board, and she's an health executive, and she has wealth of experience. She is a passionate. You can see, I wish I could measure the passion. But a medical doctor, she's practiced. She's a health advocate. She's an educator, and she joins us today as among the panelists. Please, a round of applause. And together with me, I think I have apologies, but I also have Dr. Aden.
Dr. Aden Siyat is a pharmacist.
Yes.
He's a pharmacist in practice.
Thank you so much. You just get a position which the photo will be very nice. So please have a seat. So we will have an opportunity to ask a few questions, and apologies for the slight delay that we had on today's program. So I will take my seat and then we'll go straight. Our topic for today, just allow me to sit down so that I balance off. Everyone with a mic? Yes, there's a mic. So we want to look at a very important topic, and the topic is on health workforce. And we are trying to see how do we supporting the healthcare workforce development and empowerment. And we will be trying to emphasize on looking at the need to invest in training, the need to invest in employment and empowerment and retention of the healthcare service providers. I think that is such a thing that is very dear to our heart, and then we'll be looking at also the role of the private sector in investment in the health workforce development. So maybe I'll give you an opportunity maybe to, as you respond to the first question, just to give your opening remarks. But there is something that I want us to note. That Africa, Africa contributes or takes the share of 25% of the global burden of disease. I used to get it, so I want you to figure out 25%. It means a quarter. If you have the orange divided in 4 pieces, a quarter of it, of the burden, comes from Africa, of the disease burden. You have that in your mind? The second piece, however, Africa only has 3% of the global health workforce. So you have a burden of 25%, but the workforce to take care of that problem is only 3%. Now, to add to this, currently you've heard of the mass migration to Canada, to the United Emirates, and so forth, of the healthcare workers. So we only have 3%, and even the little that we have is being migrated to other places. Now, in your view, Dr. Brenda, how would we reverse the trend and improve on our healthcare workforce numbers? How do we deal with this situation? Thank you.
Thank you, Kennedy. It's all right.
Yes, it's on.
Okay. So you said I should state my opening remarks.
Yes, please.
So first, it's truly a pleasure for me to be here and representing the Kenya Medical Association in this panel. A panel where we are having this discussion on health resources for health in terms of our healthcare workforce. As you may know, the Kenya Medical Association champions for the welfare of doctors, but we also advocate for quality healthcare in Kenya. So this is right up our alley. It's usually very exciting being in a room filled with young people. And I've seen that 90% of the attendees are healthcare workers or healthcare workers in training. So first, I think let me hijack your moderation and just say that it would be good for us to have a very interactive session. It's always good to hear from youthful leaders and people who have a new view or the other view or the other aspect of how things go along. So how do we mitigate brain drain among the health workforce? I'll speak as a professional association first. What we do in terms of championing for that welfare for our doctors and by extent all healthcare workers is, as a professional association and other professional associations, I believe we want to be a panel of, is that we form a lobby group within our country for your voice to be heard, actually anywhere. It's good to come together in numbers. So we form a lobby group, and through this lobby group, we are able to get a seat on decision-making tables, and we are able to influence policy, and you're better heard as a group. We have, as an association, been able to engage county governments through such initiatives. We've been able to engage regulators of healthcare and who have influence in that space, and we've also been able to engage governments, national governments through the ministries of health. So this is one way in which we can start the journey in mitigating brain drain and ensuring that, number one, our healthcare workers are taken care of. So that's just one way. I think I can pass it to Dr. too.
Thank you.
Thank you. In my opinion, I feel like the most important thing is the analogy of, you gave the analogy of an orange. Maybe I should further make it more complicated and give it the analogy of a lion chasing one buffalo. Just as she said, whereby the strength is in the pack. And for the longest, I feel like the young doctors, that is the MOs and the pharmacists, since the signing of the CBA, felt to have been left behind, especially by the elder, pioneers of the different associations, whether it's PSA, whether it's KMU, KMA, and whatever association that we really belong to. So that lion that is chasing that one buffalo will be able to chase it up until that buffalo gets to the park. And lions are quite intelligent. If you watch Nat Geo Wild and whatever sceneries you've been able to, that lion just stops the moment it sees the park, that buffalo being in that park. And just as the doctors really insisted on, the one most important thing right now we need to do is to be sensitize their doctors on the need about rejoining institutions that have existed, the likes of KMA, PSK, YPG, KMU, so that the strength lies in the government approaching a union rather than individuals. And this could be even further mitigated by the formation of that service committee that is aware of where its members are deployed and how different members are being handled in different counties, so that it can be able to face the different counties with one message coming from the complaints raised by them from its members in that specific county, rather than the segmented approach towards each county by different unions, when sometimes even KMTC or PSK has to be called in. So that's the most important thing. Number two, of course, we've had a discussion today in the morning about governance, and everything really comes back to governance. And I think it's time to start having a discussion on the country. What value do doctors add to this country? I mean, Kenya is now a middle class economy income, and the value that this country has is dependent on its health, and no one else provides health better than the doctors at its disposal. And if you can't take care of the doctors, then it's quite unfortunate that can't happen, especially when 3,000 nurses are shipped to the UK, 3,000 pharmacists are shipped to a different country, and doctors are being shipped to different countries. So in about 5 years, you look at the cost that the country has utilized in educating and equipping these young doctors, vis-a-vis the cost that they've wasted by letting them go. That's the most important issue. So it's about time to start having governance as a key issue to addressing this challenge. Because if after all, if we can't have an issue about governance, then in as much as we could come with different plans on a white paper, if they can't be implemented at the national policy level, as near thing as providing good health care cover for your physicians, your pharmacists, and making them comfortable at work, instead of threatening to have a dialogue, it's not necessary that KMTC has to just run a strike notice because you haven't implemented on what we agreed on. It was something that was supposed to be quite outright. So that's my opinion.
Thank you so much. Thank you so much. I'll just summarize and take your feedback. We'll have an opportunity so that we can engage further. 4 things that have come out, 2 of them are related. Number 1, there is strength in numbers. So she's talked about having a lobby group through the KMA. They're able to advocate and try to lobby so that we could address the brain drain. He's talked about having the strength in numbers so that people join associations, so that people are encouraged that it's much easier to work as a team than to work as an individual. Your issues can be much easily addressed instead of approaching it by count, from one county to another. They can have blocks. There is also the engagement with the different stakeholders that has come out clearly. And of course, one of the key pillars which was addressed in the morning is on governance. And just to have a conversation, he's brought in a very important thing that you invest. If you remember, for the people who are plant in this country, I know we have different nationalities, but I know in Kenya, if someone who is in school can easily tell us how much is your average school fee, college fee, 1 year, who is willing to tell us, who is currently college in Kenya? Yes, please go ahead.
So for regular students in School of Medicine, pay 15,000 in the first semester, 15,000 in the next semester, then the third semester is not paid. That is 30,000. Those ones are the ones who are sponsored by the government.
So
and then there are those who are sponsored, who are sponsored by someone. So they foot the entire fee. That is about 520,000 per year. And also remember that by by a regular student. Hi guys. Hi. My name is Frederick from Kenyatta University. I'm taking medicine and surgery. So the school is, I can talk about it in two parts. There's the regular student, the one who is sponsored by the government, and then the student who is coming from home and being sponsored by somebody else, either an organization or a family. So the regular students pay 15,000 per semester, 15,000 per semester, 15,000 second semester, and then the third semester they are not paying. So that's down 30,000. And then the self-sponsored student is paying about 180. It's about 540,000 per year. That tells you that the one who is sponsored by the government, the individual pays 15,000, but the government puts the rest of the money. That is 540 in a year. 540 minus 30, you get 510. So the government is using 510 to train a doctor. 510,000, and then the student pays the other 30.
Thank you. At least, thank you. I've gotten an alumni from where I was in 2005. I was somewhere with you there.
That's just in 1 year. So it runs for 6 years.
Yes. So I think I like using percentages because it can drive the point home. From the figure that is given, the Kenyan government pays 94.5%. 94.5% of the total fee. Welcome, please. Thank you. So the government pays 94.5, or let me approximate it to be 95%. So having paid 95% of the tuition of what it takes to train a doctor, then having been trained, we have deficit, we have you invest, then we let it go elsewhere. Someone else who did not train is going to have the benefits. I think that is one of the things that need to really we think through. So even as we lobby, it's important that we are able to raise those factors. Dr. Kelly, thank you. I will allow you to take up some breather, then I'll introduce you in the next session, but I'll still give you an opportunity to reflect. We looked at the burden that we have vis-a-vis the resources in terms of the human resources and the fact that we still have brain drain. So the data that we have, again, we are having put in resources, then they go elsewhere. So I think we still, I want you to ponder upon that because I'll give you an opportunity that we can say 1 or 2 words. Now, having trained them, now the next thing that we want to look at is about quality health services, which we know that for us to have quality health care services, I'll just give you again another. I like letting people know realities. For the people who are in this country, we've had a scenario where we had someone who was conducting cesarean sections. You remember the story? And had not been trained. So it's possible that it can happen. Maybe I will have to change the profession and try to see if it's possible. But this premise on number 1, we need to have qualified, not just qualified, but competent and engaged. I think we don't have a challenge in those 3. Qualified, competent. I have no doubt that the institutions, people go through them, we get those 2. Now the challenge begins on now when we deploy them, whether they are engaged and motivated healthcare workers. So take note of the 2. I don't have no doubt whether we have competent, qualified, trained healthcare workers, but there are issues about motivation and engagement. For us to have quality healthcare, all that must be combined. Now, how are we driving these different facets in our respective areas of practice to nurture qualified health professionals in our spaces? How are we ensuring that we drive, how are we driving these different facets in the different places that we are in so that we are able to nurture? Because it's one thing to have them and the other thing to to retain them. So please, Dr. Brenda, again, this is the second time that you're going first. The next one you go last.
I was hoping that the person sitting on my right would speak more than I did. When you're seated on a panel, you always hope the other people speak more than you. So just to answer your question on what we are doing, I think that's the question, what we are doing.
Yes.
So as a professional association, what do we do to ensure that the doctors who are out there are competent and qualified? When it comes to qualification, I think once you satisfy examiners, you're qualified. But when it comes to competency, the ball now is on continuous medical education. The key aspect to address to ensure competency is that are we addressing emerging frontiers in health? Because if we offer continuous medical education for what you've done for the last 6 years, it's okay to do a refresher. But are we addressing the emerging health needs? Are we addressing the crisis, the current crisis, health crisis in the world? So are we offering training on climate change? Is it forming part of our curriculum in medical schools? Are we offering that continuous medical education to qualified doctors? Are we addressing NCDs, antimicrobial resistance, mental health? Because all these are health crises currently. So it's up to the professional associations to be able to identify what is emerging and what needs attention, to be able to just have healthcare workers who are confident in managing what is brought, what is now. It has to be contextual. So as an association, continuous medical education and current and updated continuous medical education is key. Another aspect is mentorship within the profession. When we have mentorship within the profession, you find that this enhances engagement. You mentioned engagement. So engagement is when you're actually at work and you, number one, enjoy what you're doing, and you also strive to offer the best towards whatever that organization you work for is doing in line with the vision and mission. If you're not engaged with, you really don't care. Just show up at work, maybe do what you need to, but you don't own the mission and the vision of that organization. So mentorship is one of those key things that as professional associations we can do within the profession, so that also the younger healthcare workers can have learning opportunities and they can have a better understanding of the values within the profession and also the culture of those organizations. For example, in KMA we usually have these speed mentorship sessions. I don't know if some of you have participated, but it's like speed dating. You've heard of speed dating. So we have various mentees and mentors, and you have like 5 minutes with each, and you focus on a certain area and you move to the next. So what happens, you end up having a wealth of insights and knowledge from various people. So this is just one of the initiatives that will help us as healthcare workers to help us stay abreast, to be competent and engaged.
Thank you. I'll go next to Dr. Kelly speak last.
So So with regards to qualification, that is institution-based in terms of, as Doc has said, did you meet the satisfaction in terms of passing the exams? And different universities have their different bodies that oversee such kind of training. But with regards to even that, there needs to be, continuous training even when you're a student outside the medical, knowledge. For example, it shouldn't be much of the focus. Much of the focus shouldn't be just on school-based, whereby exchange programs that could open eyes and could benefit even the students more. I believe the country has taken a good step in terms of trying to implement the competency-based curriculum. And it's even time we start embracing that in the medical field as well, pharmacy schools, College of Health Sciences, because many a times when, first year, second year, you're cramming biochemistry, you're cramming physiology, and, all that. But it will go deep into the intricacies of that education system. If it really, established in such a way that even as early as first year, second year, you can go for, an exchange program and learn about certain things and be exposed to climate change. Because climate change right now is an inevitable issue. It's something we can't forgo. And Africa contributes less of the carbon print, but we suffer most. And if our workforce is not aware of that, then it's a catastrophe that's boiling down to them. That will take us down to the gutters. So with the qualification, I believe it's time we have a conversation about our curriculum in terms of medical schools, pharmacy schools, whereby there shouldn't be this mentality about just only, passing exams and then doing the oral exams and sports, all that. It's about time we have, the lecturers that even assign students from first year, where they could go with their different, facets of work life and be able to introduce these students. And as soon as this student gets to third year, fourth year, they can be able to say, because I work with Dr. So-and-so, I feel I like this about medicine. I like this about pharmacy. And I like this about, that. And that will be able to even further, set on motion certain conversations that we do not have and embrace emerging issues and even get ready for the next emerging catastrophe or a pandemic that could, come. That's with regards to qualifications. With competency, I wouldn't insist much, but the most important thing is the bully mentality that is around the corridors of the walls and the ego brushing with respect to the physician and your senior pharmacists, where you can't contribute to certain things because you're relatively naive and you just want to pass that semester or you just want. There's now that point, where you can ask the physician, Doc, wait, I feel like this sodium is not right and you didn't see it. Doc, wait, I don't feel like these creatinine levels are confident with them. And then that physician will be like, what do you think? And that will spur a conversation. And then that student will be confident enough to next time be able to challenge the status quo, but in a more respectful manner. But the bully mentality that is around, it's really bruising. I mean, an intern who has been working a whole weekend shift and you still expect him to come for the next rotation on a Monday morning and then still be as efficient as 100%. And if it doesn't come, to start lecturing him, when I was an intern, I used to do X, Y, Z. You are there. It's new. And I feel like, as a country, we need to embrace labor laws and then really advocate for them, because the current labor laws are porous. And the suffering starts from as soon as, whereby I don't need to be around for a work round from 7 and then be over at around 2, standing all that time, serve over 200 patients, pediatrics, adult patients, and still complete the files, fill the T-sheets, do all that. By the time your day is done, it's around 6 p.m., you're still on call. I mean, that is why right now the suicidal rates in terms of healthcare practitioners and the young doctors, quantifiable amount of service at a certain point in time, and he is remunerated or she is remunerated for that. Otherwise, just because you're told you're earning a CPF, and it's a lot of money, and you need to do this, do that, do this, do that. It's not. It's time we have a conversation about this bully mentality. And I think that is what is really curtailing us in terms of competence, whereby as an intern you can't ask a seasoned, pharmacist, a seasoned physician, why are you doing these tests? And you can't have a logic with him and explain to you. I feel like in my time, I've had 5 patients who behave like this, and this is what I did. Because in one way or another, you're fearing that there could be a repercussion to you opening up your mouth. So that is with regards to competence. And in terms of engagement, just as I told you, team building, teamwork, different activities. I've seen PSK has worked a lot with that, and sometimes PSK and KM has also been doing, whereby you call a doctor's conference, the recent one, the young doctors, something like that to engage outside work activities so that these people can meet the mentors they're really looking for. Mentors can't be found in boardrooms, they can't be found in hospital wards. You can have a conversation in a relaxed, empty, with sound, whereby you meet in such a kind of a conference and you can talk about how do you see I have just finished my internship, what do you think I can put my foot in? And he could tell you this is the contact of someone who does this. Go talk to them, and I'll give them an insight before you go to them. And go talk to so and so. Let them give you a volunteer remark. You go try out. If you're convinced, then take up. You go do this. That engagement comes with the intricacies and imbued culture whereby these societies can be able to cater for the young doctors and be able to take care of them. There is a really much struggle that comes from the entry point when you're getting to the internship itself. There's a lot of brush shouldering with MOH, and you really feel demotivated. And with regards to that motivation now, certain things are individual. I mean, I can't, just as you said, I can't measure passion, you can't measure passion. You can't measure someone's motivation at work. And motivation is, dependent on a lot of factors. And part of that motivation is, if, let's say, you go for internship where you need to test everything. You need to be at the surgery, you need to be this, you need to be in that, you need to be this. But if you say something like, a huge chunk of your internship should be something you really feel you're motivated to do. Like, let's say I'm interested in geriatric pharmacy or industrial pharmacy, and part of my large chunk of my education should go towards that, whereby I go try what I really want, and if it fails, I'm still given a part of my time to be told, okay, go try again. The rest, it's not just a systematic way you're told you have to finish in 12 months, a rotation, rotating in different, departments. So motivation also comes with, things to do with better working conditions in terms of labor laws, as I've told you. You don't expect an intern to provide you with the service provision at maximum capacity from January to December. There's a time you burn out and you don't feel going to that. There's a time your mom or someone else is feeling, sick at home, and your mental, space is not being clear. And you need to debrief. And this debriefment and this, motivation comes with an open society. And that open society cannot be embraced in a bully mentality. So it all boils down to, you could have a change. You could see this intern as your own son, if you're a physician, or as your own daughter. Yeah.
Thank you. I wish someone was recording this, the way he has spoken with lots of passion. So before we revisit that, but allow me to welcome Dr. Kelvin Odongo. Is that right? It's Dr. Kelly. Oh, sorry. This is Dr. Kelly. Dr. Kelly is a pharmacist. Right? Yes. and he comes to us. I think part of might have our schedule, it was January, so apologies for coming late. So Dr. Kelly, I will give you an opportunity again during the closing remarks to say an extra word. But how do we address the issues about competencies, the issues around motivation that he has talked about in your area? Thank you.
Okay, thank you so much. Let me start by apologizing for being here late. I think there was an unavoidable circumstance in the office. My name is Dr. Oluoch, the Chief Executive Officer, Kenya Medical Training College. The college is graduating tomorrow, so that's one of the issues I was handling before coming here. Now, let me tell you about Kenya Medical Training College and then answer what I said here. Now, this is an institution that was started in 1927 with 4 students. Right now, the college has 54,000 students, and tomorrow we will be graduating 16,000 graduates. Now, it therefore brings close whatever we are discussing today about quality, competence, and engagement. Now, the college has 18 departments, 7 faculties, and 93 courses. That's quite a number of courses. We have 72 campuses spread across the country, and we have 8 satellite campuses, bringing them to close to 80 campuses. Now, therefore, the question of quality comes in, the question of competence of the people we are producing comes in, the question of how we engage them to make them contributing members of healthcare fraternity comes in. I will then now go to the issues of how we address qualification, how we address competence, and how we address engagement. Now, Kenya Medical Training College is ISO certified. That means it is ISO 2015 to 9001. Means that from the word go, we document all the processes from the point a student gets selected to Kenya Medical Training College, their qualification as they're coming in. That is what we call entry criteria. We look at from their induction into their courses which they are going to learn for the 3 or 3.5 years, their timetabling, their class attendance, their performance, the issues about their promotion, the issues about how to address what is called corrective and preventive actions, how to ensure that the people who actually arrive for final qualifying examinations have actually met the requisite number of hours, they are competent enough, having gone through clinical placement areas, having gone through class attendance, they are able to perform at bare minimum, they are able to meet regulatory requirements. Now, we have a basic requirement that each student must attend at least 90% of their classwork, meaning that anything below that, they are not allowed to do an exam. So we always ensure that all these things are recorded, and because we have an ERP system, we are able to ensure that we can actually account for every student that goes through our program. By the time we qualify these students, we want to ensure that they are able to do what is called fit for purpose. They are able to do what they are expected to do. Now that is about qualification. The other issue we do is to make sure they are qualified to do what they are supposed to do is regularly review and develop curricula that meet the expectations of the market and the mother ministry. We are the training arm of the Ministry of Health. So we must make sure that the people we are producing are geared towards the demands of the ministry, are geared towards the demand of the market. For example, there is a lot of need for what is called point-of-care ultrasonography, so that we have nurses who are able to detect the need for emergency care for our mothers. We have to ensure that we are able to produce curricula that enable such interventions to take place. We have what is called echocardiography. This is a new course that enables people to address emerging issues. We have what is now called occupational manual therapy in physiotherapy, a very new area that has never been practiced in Kenya. So we make sure that we look for the gaps in the market and make sure that our curricula address those gaps, so that we have people who are qualified to practice. The other issue is what we call preceptorship. We work with the people who supervise our students in clinical areas, attachment areas. We have a way of engaging them to make sure that they know how to instruct students in the clinical areas, and then we supervise it to ensure that the students are able to actually practice a skill and be able to repeat it until they are able to master it. But even before that, we invest so much in our laboratories. We have what is called skills laboratories. We put a lot of our resources in ensuring that even before that student assesses a patient, they have practiced sufficiently in our skills laboratories to ensure that they are able to practice in a mannequin to the extent that they are able to apply the same on a real patient. We now have moved so much in terms of skills laboratories that we have what is called high fidelity mannequins that are able to mimic human reactions actually perfectly, so that these students are capable of practicing in a mannequin before they are able to access a real patient. Now we even move further. We have what is called we have skills lab that are able to even be, we have procedures that can be transmitted or shared. The procedures can be shared among all our campuses at the same time. That is to ensure that we have qualified students at the end of the day. The other issue we do is we sponsor conferences for our lecturers so that we continuously retool our lecturers. For example, we have in the last 2 weeks been sponsoring professional associations like Clinical Officers Council to make sure that our lecturers go present papers, they're able to get to engage with other practitioners in the field and be able to bring that knowledge back to the lecture theaters and lecture halls. The other issue is we encourage our students to be lifelong learners so that they don't just get their qualification, leave, and stop learning at that point. The other issue is faculties from other countries. Today, just before I came here, we were discussing on occupational manual therapy and being able to get skills from US. So we have had, for example, today professors from US, what is called the Jackson Clinic, to be able to support our higher diploma students to get the skills that are not available locally. The other issue we do is a lot of partnership. Like now we have a collaboration with Aden University for exchange programs, so that we have our students going to Australia and their students coming here to be able to learn different things that they would otherwise not be able to learn in a normal way. In order to make our students be engaged, there's something we do about what is called, we have a club within the college which is called the Presidential Award Club. This club engages students real time in community services, and actually they even get awarded by the president himself. We've done a lot of awards, we've gotten a lot of awards in this area so that our students are not only bookworms, they're able to engage the community, be able to do a lot. We also do what is called the open days, where our students, our lecturers, and the whole community of KMTC engages with the community in blood donation, in medical camps, to be able to make them engage people in the community. Then, again, we work so much with our regulatory authorities to make sure that competence is actually entrenched in our system. Thank you.
Thank you so much. If you've never heard about KMTC, I think I'm convinced that I need to take someone there. Because with all that he has outlined as the structure, I think I don't need to repeat what he said, and each and every institution has put in some food for thought. Before I summarize, I always give this hotel versus institution. I want to remember that story. Hotel versus institution. Some years back I was working with KMTC to try the one of pay as you eat, pay as you. I think I was part of that team that removed that people just eating and the student paying directly. One of the challenges that we've had is that all of us are a product of institutions. You come out of a training institution, whether it's KU, the person from KU, KMTC, and all other training institutions. Then we go to the job market. Now we are healthcare workers. What happens for our in-service trainings? Did you remember what I said? Hotel versus training institutions. So we are saying that at one point, the training institutions wanted to be hotels, meaning they peg their admission based on bed capacity, and the hotels are coming up with where to train them. So each and every person wants the other person's role. I'm one of those people who believe that in-service training should actually happen within the training institutions because of their mannequins. Like, there are things that facilitate training better within the training institutions as opposed to having an in-service training at Hilton Hotel. But that's just a food for thought. So thank you. I can summarize again. I think the key point that I got from him, he said many things, but one that I do not want to get lost is bully mentality. That the young doctors, the young healthcare professionals feel intimidated, they may not be allowed to innovate, they may not be allowed to express themselves, and maybe we need to, Dr. Kelly, think about the curriculum to try and address that. Work with the association to try and address that, because we are in transition. So at the end of the day, and if you I believe that it doesn't happen now, like it has not started now. So maybe when you grow and become more experienced, be the change. Be the change. So I think I want to go to the next question, because we are trying to move towards the end. One of the biggest questions that happened in this country. Yes, thank you.
I took the mic. I know I was supposed to be last.
Yes.
But I took the mic because I just wanted to weigh in on what Dr. Oluoch mentioned. There's something he said that, and it's not a debate, but I want us to just have clarity. As much as we are training to meet the market needs and the market demands, it's very important for us as healthcare workers to be able to clearly distinguish the roles of each other. Because when we have overlapping roles, or maybe what you're trained for is not what you're going to do in the market, then that compromises on quality of healthcare services. I'll give an example of where we have cadres that are trained to mostly provide primary health care. You find them offering tertiary level services in the community. So that's where these issues come up, and you find we are on a microscope, the healthcare system as a whole. And healthcare workers are put under a microscope because now quality is compromised, and we are not offering the population what you're trained for. So be the best you can wherever you're trained and offer the best services If you're trained to be a medical doctor and a surgeon, with the 2 degrees, do that. If you're trained to be a pharmacist, do that. If you're trained to be a clinical officer, do that.
Great emphasis, and we can continue the discussion. Thank you for that emphasis. Now, I think I'm going towards the end. There was a discussion that happened in the year 2008, 9, and partly 2010 before our new constitution. But that is in Kenya. When people were in Bomas of Kenya, there was a section for teachers and there was a section for doctors. The section for teachers was always full, and the section for doctors was always with few people, and hence teachers took advantage and added more. So when the decision of devolving health was being made, also the order of education was being made. Education was devolved, the teachers went up in arms, the doctors were so busy, they were treating people, and when the health was being devolved, they didn't know. So we did an election for the referendum, and we have hopes. The new constitution and health is devolved. I hope you've heard the story. Now, we are in a scenario where the effects of that new constitution has been felt, because health has been devolved. And the devolution is so that the management of healthcare is so different, even in terms of the roles, like the positions and things that the transfer or even moving from one county to another is possible but a challenge. So the current discussion that is going on is the push for health service commission. The way we have the teachers service commission. What's your view on this? And what would be the key pain points to be addressed by the health service commission, if it were to be? I'll start with Dr. Kelly.
Okay, thank you so much. I'll advocate for health service commission. It will address things that are not able to be addressed by regulatory authorities, and it provides answers to some of the things that are currently a challenge in our system. The first issue that we need to address in health is equity. You find counties with varied skill sets. There are counties which cannot do simple procedures because they don't have personnel. We have therefore the Constitution in Article 43 says that all Kenyans are supposed to access quality health care wherever they are. We want to ensure that a patient in Mandera is receiving the same type of care, that is quality care, like a patient here in Nairobi or a patient in Busia. That currently is not happening. The counties are working like silos. Each county is doing what they are able to do, and at the same time, the administrators in most of the counties are not so much aware of what it takes to provide quality health care. A commission of this nature will be able to address matters of equity. The other issue I'm looking at is the element of security. Right now, we have pandemics coming right, left, and center. Each county is not as prepared as the other county. Another county is not as good as another county. We have, for example, cholera outbreak that we started in Kiambu. Within a short period of time, this has spread all over. Nairobi is not even just being the next neighbor of Kiambu. But you want to ask yourself, are patients accessing care? Are we able to work uniformly to address emerging issues in a timely way that prevents spread a catastrophe. Or sometimes what we also need to ensure that we do not have also overspending by certain counties compared to others because they do not have that kind of care. They have to go to another country to get that. So to me, a health commission will provide a given extent of security to patients to ensure that it is possible for service delivery to take place without the struggles of boundaries. The other issue I'm looking at is in terms of standards. There is the need to standardize health. As I've told you, the staffing norms are not the same in all the counties. You find Nairobi having a higher concentration of specialists compared to any other county. So a patient who needs specialized care in Migori has to travel to Nairobi. There is no standardization of care because there are pockets in this country where care is better than other areas, but they are all citizens. They all require, they also pay tax. They require a given standard of care that we as a nation have bestowed on ourselves that each and every citizen of this country is supposed to access a given specific standard of care. But is it happening? It is not currently happening because we have differences in terms of standards of practice across the country. I believe that having a commission like this is going to help us to be able to standardize health. I want to give you an example. We have Vihiga and we have Kisumu. These are two counties that are neighboring each other. The amount, the quality of care, let's say at Jaramogi University and the Baro Hospital, is way far different from the care that is given at Baro. Why? Because of resources. And you find that if you find a county that is not able to manage cross-border issues, then the county that is disadvantaged in terms of the standards, the norms, is going to have a poorer quality of health compared to another county that is properly resourced. So we want a situation where all Kenyans access quality health. And that is a promise that is in the Constitution, it is entrenched, and one way of addressing it is to have a way of managing human resources that enables care to be spread across the country in an equal manner. Thank you. Thank you.
Thank you so much.
So you asked the question when the Constitution was being made.
No, the question is
No,
yes.
So when the Constitution was being made, the teachers were present. Where were the doctors?
No, I didn't ask that.
No, that's the same question that is usually asked everywhere. But I always ask the other person, where do you think the doctors were? No, they were not. They were not made aware. One, for a fact, maybe I was younger then. I didn't know about it right now. But as a country, then whoever was put in place to sensitize people about the need for new constitution was supposed to do advocacy. You don't need to send your soldiers into Somalia and expect them to be back again here for a referendum if they don't know the need of that referendum. So at some point, there was something that really, there was a gap that was created whereby the teachers were sensitized, or maybe other different professional bodies at a national level were sensitized, but the doctors weren't. For one reason, the escape bodies, they were in the hospital. But if those who were off that day, could they not present themselves at the Bomas of Kenya? They would. And if that happened, they were not available. What was the government in that time supposed to do, or whoever was put in that place, is to call and have an amicable solution on how to address. But deep down in me thinks that was really not necessary then, because it was a trial and error, whereby, of course, right now, a constitutional process is through negotiations and amendments. We learn from different legal, perspectives, and we keep on growing. Just in the same way, during the first elections after the new constitutions, there was a presidential dispute, but who was supposed to address them was not given to the constitution. But the legal team sat down and came with a solution that is to be addressed by the Supreme. Now, 10 years later, can we not have an amendment through, of course we've seen the challenge, whereby doctors are just left down in the gutters and, health is being compromised. But till when we keep on crying foul and keep on saying that, a county is so and so, that is affecting you in as much as it's affecting me, in as much as it's affecting everyone sitting here and everyone walking out there. So, should you not think of it that we should have this conversation right now? Then why do we keep on dealing as a country? Every time a new government comes, things like health, education, defense, shouldn't be with respect to the government of the day. It should be a long-term government. That is a policy that is, 150 years, 200 years to come. We shouldn't be talking about Health Service Commission when we've already seen how things are going. The other need as to why we need a Health Service Commission is health is not an issue to politic about. Because in as much as we know the value of health, do our governors know the value of health? Because if they really knew the importance of health, every citizen in their respective counties and in their respective wards, and every constituent in the respective constituencies, then should have really, made that governor aware of the fact that, yes, I need a consultant surgeon, I need a pharmacist, clinical pharmacist, I need a, a warehouse pharmacist to manage the drugs, I need a nurse, I need this and this. Then, if now we start to take shortcuts to compromise on quality, as doctors say, whereby we start looking for short fixes in terms of addressing the issues, then that now becomes a challenge. So, if I was telling someone here around lunchtime, if you go for an interview and you're asked about the question, like, how much do you expect for this, for this post? Someone lectured me and told me, ask back that question in a manner to evade it, and ask them, what value do I hold to you as I'm sitting in this position? What value do I bring to this company? They explain to you the values. Then you ask them, how much are you willing to pay for that value? That is the same discussion we need to have about health with the government, with the people in leadership. And then from there on is now when we can talk about HSC and its roles. Standard of care, and disposal of resources in terms of human resources, in terms of deployment, in terms of security, in terms of job security. And after that, then when we have a value and we have a guiding principle, then we can form an agency. But right now, we need it, but we don't want to really means to have an agency.
Thank you so much. Brenda, last but not least.
Thank you. I usually make a joke that doctors are not the best politicians, but I'm seeing Dr. Aden. Will represent us well very soon. So on the Health Service Commission, it's definitely a step in the right direction, because we've seen, I don't know whether to call it teething problems with evolution on matters health, but we've seen the effects of not having a centralized and centralized body to deal with matters of health workforce. In 2017, we were able to see, I know the doctors had 100-day strike, and the nurses also had 150 days, so it's 250 days down. So you can only imagine the magnitude and the impact of that on the Kenyans who were seeking healthcare. Why we support the Health Service Commission is number one, because it will improve efficiency on deployment, on anything touching on healthcare workers. And the goal is to have a Health Service Commission that does not offend devolution, because devolution is good. It's good if you come from, let me say, a county that's less privileged, because slowly we are growing. And you see the fruits that devolution has borne. But what we have seen is that it does not work when it comes to the health workforce. For other health services, it's super, because it will grow our 47 counties in terms of health. But for the health workforce, when we have over-fragmentation, then we don't have efficiency, and as Dr. Ken mentioned, he mentioned that access and equity, because we have those counties that are more privileged, we have those that are less privileged. So we end up having a situation where some counties, there's the poor man's health, we offer poor man's health, and then the counties that have the muscle, we offer them now the quality health care. So that's it.
Thank you so much. I think we can give them a round of applause for that. I think I'm going to stop without asking this question. Who is currently championing the idea of the Health Service Commission? You may not need to answer. I'm just saying that if we don't have someone holding it, because I know this country allows no private members to introduce a bill. I've not seen where it's been introduced and it has failed. If it is advocacy, we've advocated for long. It's time we act. Someone must take responsibility. I think Dr. Brenda said that KMA and other associations have an opportunity to jointly work together and say, if the politicians can't do it, we want to try it. Let's try it and say that it's failed. But again, the way you say, there are many good things about evolution. There are places that have never had hospitals that have now had hospitals. An opportunity for partnership. I see the timekeepers that we are 5 minutes. Or based on my time, we are 1 minute past time. So just quickly, before they give parting shot, anyone with a burning question? Or 1, 2, let me just give them this mic. So there's 1.
Okay, let's remember the qualities of a good question. So that means, what are the qualities of a good question? Keep it short and sweet. So, I'm going, okay, lift up your hands if you have a question.
Allow me to give them numbers, because
I can take all of them, so I don't know.
No, there was that lady, 1.
I'll take the lady over there.
This lady here.
And that guy who's, it's okay, next time.
It's okay.
Good evening. So my name is Dorcas from Kembu, and I have a short question. So on the issue of
Could you choose your 1? Then I give her the chance to also ask 1 and him 1. But it's not a must that you have to answer all.
So on the issue of the Health Service Commission, you talked about the doctors and the teachers. Now, on the way the presentation was made, I think the Health Service Commission seems to be like the solution to most of the problems that are affecting the doctors, the pharmacists, and the nurses. But now, the other day I was talking to my father, a teacher, and he mentioned that by the time they were finishing school, now since the Teacher Service Commission, they were getting their employment letters and then they were getting posted. Now, what about maybe 10 years to come, when maybe, I don't want to say that the teachers are flooded, but nowadays when a teacher when they get to finish their school, they will take 5 years to get employed to be posted by the Teacher Service Commission. So when that comes, how are you planning to address that?
Good evening. My name is Steve Brenda from Aden High School. So I have one question. You talked about the brain cave when you were introducing the topic. So I'm curious, do you think the Marxist theory and the political and capitalism in healthcare is impacting on brain death increasing? Okay.
My name is Mary. I'm a fourth-year medical student from Aden University. And I have a question. You guys have mentioned that competence, continuous learning process and training is key in the production of competent doctors. Now, I'm sure you're aware of this issue that has been happening in our country, whereby it has taken 8 months for our finalists to go for the internship. And now, do you feel like that is like a step in the wrong direction in the production of competent doctors, because you have like an 8-month break before you go for your internship? And also currently, like now, I'll be joining by 4th in January, and I did my exams in August. I have like 4 months at home just wait for me to do it for here. Do you feel like that delay in transitioning to my clinical years is kind of going to make me feel like I'm losing something in the next 2 years? Thank you.
So I think I'll request each of you just one. Dr. Kelly can address the last question. She can, I think the Health Commission, I can, whoever feels philanthropic, answer it, and then we just finalize. And as you answer, you can also make your partnership.
I could want to address the first question.
Yes.
Thank you. The issue of 10 years to come and the employment of bioproducts, especially those who have just qualified. This is a concern. It's something that is worth addressing now. Number one is whether, as a country, put priority on employment of bioproducts. Number two, 10 years to come, we will have really been into a CBC environment where we will have too many students in med school, in medical training colleges like ours, graduating. If now we are just, now we are in 2022 and we are graduating 16,000. 10 years to come, probably we will be graduating 30,000. I'm not sure, but that could be a possibility. Will all of them get employment locally? The answer is no. And what then happens? What is the priority of training institutions? What is the priority of government when it comes to employment, transitioning from student to employment of health workers? As an institution, we are doing something about this. We have realized that apart from advocating for our graduates to be employed by accountants, which we really do, there's something else we're doing. We are establishing what is called a liaison's office. What we mean by a liaison's office is we are now starting to realize that beyond just training and telling people you take care of yourselves, it's your problem after you get qualified. We now realize that there is need for an educational institution like ours to link the trainee to the market. And now what we're doing is to ensure that we have an office that enables our qualified trainees to access job markets outside the country. What we are doing now is we are opening up to non-traditional ways of doing things. We are looking at, for example, if Germany wants health workers, and for your information, we were engaging Germany on Monday about exportation of health workers to that country. What is required from us for our trainees to be market ready? So what we do is to start asking ourselves, can they learn to speak German? The answer is yes. Then what is our role in making sure that they get that pre-departure skill? Is to look for institutions that will help us or individuals that will help us impart specific skills for a country that requires our help. And we are really investing in that and talking to embassies and talking to health attaches and making sure that we set real targets towards ensuring that by the next 4 years we will be exporting at least 5,000 health workers every year and customizing their skills to the country where they are going. We are already working with UK, but now we want to work with Germany, we want to work with Australia, we want to work with Canada, we want to work with US. We are even doing a partnership with Pearson Group to make sure that the examination for nurses, instead of them going to South Africa or to India, to qualify to go to US, we do it at Kenya Medical Technical. We are working with the British Council. We already have an English examination center, training center, to make sure that our health workers are not destined to unemployment. Another thing we are doing is to do what is called health entrepreneurship. We train our graduates to not only wait to apply for a job, but also to be job creators. So we tell them, apart from learning pharmacy, how do you establish a pharmacy? How do you run a pharmacy? How do you account for your profits? How do you make sure that there's efficiency in operations? We link them to the leaders. Right now we are working with Philips Pharmaceuticals so that there is that written industry learning at the institution, so that we don't produce road runners, we produce market-ready learners. People who can go to the environment, be able to be entrepreneurs, create jobs for other individuals. So that is what we are doing to make sure that in the next 10 years, we are not suffering from overproduction or a glut or a situation where graduates feel cheated because they have worked so hard, yet there's nothing to show for it. The other issue is what has been asked about losing time between class hours and being able to link into the practical sites. For us, what we do is to have partnerships like MOUs so that our trainees do not wait. They do not wait to go to the clinical area. We are now having partnerships and MOUs with counties, clinical areas, training preceptors, mentors, to make sure that our trainees finish within the stipulated period of time. As a matter of fact, right now we have what is called 95% transition rate from the point a person gets admitted to KMTC to the point they leave KMTC with a qualification. 95% of those who get in today are sure that within 3 or 3.5 years they will leave competent and ready for the market. Thank you.
The topic that we are handling is the heart of why a good number of us are here, health workforce development. So please don't feel pain when we've taken time. I think on behalf of everyone, I want to say thank you for listening, thank you for picking up things. There are things that are picked up. As inSupply Health, where we are, we do so much on health, just from the name, inSupply Health. So we are in the supply chain, so we work with a good number of you, healthcare workers, the pharmacists, the people who handle that particular role in those particular places. We advocate, in addition to the traditional learning, please, if possible, we take the blended learning, the self-paced after school. There are many things that can happen. So with those few and lots of remarks, thank you, and thank you so much. the speakers. See you next time. Bye-bye.